Go live. You can start.
Good afternoon, doctors. On behalf of Heathrow Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors, at Heathrow, we market products in different therapy areas like in gynecology, orthopedics, derma, etc. We have very strong R&D support, and we have developed many unique formulations keeping patient benefit in mind. Recently, we have introduced Carbetocin. Carbetocin, as we all know, is used for prophylactic management of PPH. PPH is a condition which can lead to disaster. We'll agree with me. It's always good to read on PPH rather than see a patient on PPH. While there are several papers and guidelines which suggest the use of Carbetocin, it is important that we know experience from practicing doctors on Carbetocin. For that, we have eminent speakers to give insights in their experience with Carbetocin. Today, we have got Dr. Kiran Chandna to share her experience on Carbetocin. Dr. Kiran Chandna is MBBS DGO, FICOG, CIMP, PG, DUSG. Madam is Director, Chandna Medical Center at Faridabad, President, Faridabad Obstetrics and Gynecological Society, VP, Faridabad Menopause Society, Joint Secretary, HAR, OBG Gynec Society, Organizing Chairperson, MTP Con 2022, Organizing Chairperson of Cadaveric Dissection of Internal Iliac Artery 2023, Surakshit Nari Award.
Thank you, sir. Thank you, sir. Thank you, sir. It is all right.
Madam has written chapters in Foxy brand, has co-editor Foxy, publications in various journals, national coordinator for MTP committee, active participation. Welcome, madam, and over to you for your session.
Thank you, sir. Thank you, sir. So we all know that. So good afternoon, everyone, for joining the webinar. We all of you are very experienced physicians. I know that Carbetocin is one of the new molecules that has come in recent past. So my experience with this is previously we were very afraid to use this because we were used to using the oxytocin, methargine, then came the misoprost. Now the Carbetocin came, and so first case I did was there was one woman, she was multi-gravida, she had precipitate labor and she was moderate anemia. She had previous risk of PPH, of history of PPH, that was the risk factor, and also the precipitate labor, that was the risk factor, also the moderate anemia. So I tried, in this case, I had given Carbetocin. The result was that uterus were well contracted, there was no PPH, and only moderate amount of bleeding was there, and there was no difficulty in removal of the placenta, and both the baby and mother, they did well, and there was no problem in breastfeeding of that baby also. This was my first case that I did use for. After that, I tried in other patients also, and I found the good result. Next slide, please. Next slide, please. Then came there was a patient who she was posted for LSCS. She was a previous case of LSCS, and she was posted for elective LSCS. She was moderate anemia, but the patient was not willing for blood transfusion. Although we matched and cross-matched the blood for the emergency purpose, but patient was very insistent that she will not get the blood transfusion if there be need. So I had to act very in a prophylactic way, that she does not bleed much, and I had to, because she was also previous cesarean section, there might be more adhesions also, there might be more bleeding also, there might be chances of placenta accreta also. So I, in such cases, patient, I use prophylactic use of Carbetocin, and to my surprise, there was no PPH, there was no need of blood transfusion, although we gave injectable iron to that patient after that, but the acute emergency was not there. So I found this drug very useful, and this encouraged me to use it further. Then my other case I will like to share with you is, there was a primary gravida. She was obese patient. She had got gestational diabetes also. She was mild pH and she was to be taken for NSCS, and we knew that because she is obese, slightly good sized baby, she is PIH and gestational diabetes also, primary also patient, she is likely to have PPH. So we can't use methargine in such patients. So I tried carbetocin in such patients, and also we kept the oxytocin and misoprostol in balance, that way if we don't get the results. But only with the one dose of carbetocin, the uterus was very well contracted. There was no need of repeating the dose also, and there was no PPH, no extra bleeding, and I could manage that patient very well. So, and even in case of mild preeclampsia, I could use that drug, and it was very good experience for me. So after that, we kept on using all these drugs, and I encouraged my other colleagues to use it also. And this is my few cases I can share with you, sir. Not
It's
able
very,
to
very
hear you,
interesting.
sir.
Yeah. It's very interesting use in gestational diabetes. I mean, I was not sure, in diabetes, it can cause uterine atony. But in one case, you said that you would not give methargine. Any specific reason?
Excuse me, sir.
What this, I will say you, this gestational diabetes, you said methargine was not to be given.
No,
Any
because she was PIH. She was
Okay, okay,
PIH.
okay, okay, okay.
PIH.
Huh.
So we didn't want to give the methargine.
I understand.
Yes.
And madam, you have used carbetocin over a period of years. May not be in all patients, but many in many patients. Have you seen failure with carbetocin anytime?
Sir, I found it, but I'm not able to hear, sir.
Have you seen any failure with carbetocin?
No, sir, no. My experience has been very good. In almost all the cases, I had the very good experience. There was no much bleeding was there. Uterus was well contracted. I never felt to give the other oxytocics along with this. No need of methargine, no need of misoprostol. Had to be, and even the side effects were very less. They were just nausea and vomiting patient, as we see in other patients. And if we give it in the intramuscular dose, there was less side effects. When we are giving IV, we have to give it slow IV over 2 minutes time in diluted in 10 ml. So usually we give in the with the if there we have got some other assistant also if the patient has got any problem, so that can be handled side by side, because we as obstetricians are at the patient end. So if there is anesthesiologist or if there's physician or some assistant is there who is very well qualified, that gives us confidence if there's some problem. It is because it being new drug. So I found it very good, and there was no secondary PPH also that in those patients.
Any, I mean, like oxytocin is known to give little effect on ADH and retention of fluids, etc. With
There was
carbetocin, have
not.
you seen?
It is known to be less antidiuretic agent.
Less.
So I found it good, and there was no congestion or etc. There was no because I am not using the cardiac patient, but mild in severe cardiac disease it is not to be given, but in mild cardiac disease we can opt for it, but we have to take that the patient is not compensated.
That's correct. Yes. And thromboembolic episodes, so you have never witnessed.
Yeah, that's
But with the prostaglandins, I suppose sometimes you do get thromboembolic episodes. Is it that you get with oxytocin thromboembolic episodes?
Not much.
And which patient profiles where we can expect or anticipate PPH?
We can anticipate PPH in patient if the age of patient is very less, like in teenage pregnancy, or if it is an elderly patient, then we can get if the patient is multi-gravida, if the patient is primary gravida, if the baby size is good, is a good size baby, or the patient is in prolonged labor, or the patient is obstructed labor, then we can, if there's twins or if there is any history of placenta accreta, or then we can find, if the patient is hydroamnios patient, in
Even
such patient,
uterine
if the
yes.
patient has got any history of PPH earlier also, PIH patient, gestational hypertension patient, or the gestational diabetes patient, we can get the
Fibroids
patient
also, yes.
pregnancy with fibroid, we can have
Anticipate.
the anticipate PPH. So in such cases we can use the prophylactic use of oxytocin, carbetocin, or we have to keep all these drugs in our box, so that if there is an
Absolutely,
emergency, we have to
absolutely.
just give these medicine.
We don't have time to run about.
Yes.
And patients with diabetes and hypertension, obviously they've got compromised function. They would be, I mean, does the patient who have passed their due date, are they more prone for PPH?
Sometimes, if the size of the baby is good.
Okay, huh.
One of my patient had she was post-dated, and the baby size grew to so much that the muscle fibers, they were just apart. So in that patient, it is very long time. I think it is 25 years ago.
Oh my God.
So the patient was not willing for cesarean. Ultimately, I had to do cesarean. So ultimately, there was atonic PPH, which I was not able to control. In those days, in spite of everything, I was not able to control that. I had to resort to emergency hysterectomy in those cases, in that patient, because in those days we were not aware of B. Lynch and the hemostatic compression sutures. That was not available. I think it was in 95.
Madam, I'll share my case. I mean, it is in late 70s, 78 or 79. When my stint in JJ Hospital, Mumbai, we saw one case of PPH, and I'm happy and glad that I saw only one case of PPH. I mean, we had only oxytocin and methargin. You can imagine late 70s. And the whole unit was there. I mean, it's an emergency to the nth or N level. By God's grace, the patient was saved. Dekhte, patient delivered and she went into PPH. We expect the unexpected. That's exactly what although there are profiles, we can expect the unexpected in case of PPH. Very correct. When would you prefer carbetocin or oxytocin for prevention of PPH?
Sir, whenever there is risk factor is there, or if the patient is high risk for PPH, I will prefer carbetocin. But I will first rule out if there is any contraindication for carbetocin. Because the carbetocin is, and I will use if there is the hospital where we cannot maintain the cold chain, or their refrigerator is not available, or if the temperature is quite high. So in those cases, I will be happy to use this. Otherwise, if the patient has got any mild case of placenta accreta, or if it is a good size baby, patient is in obstructed labor,
high risk patients, all high risk
pregnancy, I will like to use this drug. Yes, I will like to use this because I found the result good. And in patient who has got history of PPH in last pregnancy, I will definitely use this drug.
No question. Yeah, correct. We can't take risk again.
Yes.
Can
anemic patient also, I will like to use the carbetocin.
Yes. Even patients with lower socioeconomic status, if they're anemic, they may be multinutrient deficiency. Like even calcium deficiency also can lead to atonic uterus.
Yes.
The contractions may not be strong because of calcium deficiency.
In patient whom we have seen that there was a difficulty in the induction and there was not good uterine contraction. In such patient, if we do cesarean section, sometimes there is atony is there. Something is different in their contraction of uterus.
Correct.
Previously, first they don't get the contraction, and after that they don't contract well. This is my personal experience with the.
That's more important. Yeah, this is what. Can we use carbetocin in case of retained placenta?
I think we can use in the retained placenta, but if it is not if it is a mild adherent placenta, but if it is per creta or it is in creta, I don't think it will be we will be able to. It won't be fruitful. Otherwise, if it is mildly adherent placenta, or just if there's leaking PV and placenta gets adherent to the
the os should also remain open.
Os still remains open, then we can
Yes.
So, but in some cases, they have seen that if they are using, for previously we were using oxytocin, we were injecting 10
Yeah,
units
yeah,
of
yeah, yeah.
oxytocin and 20 ml of the
Saline.
saline
Yeah.
into the umbilical vein.
Oh,
So yes, sometimes if we use this carbetocin, there has been one study. If we use this carbetocin instead of that, these results are better as compared to
intramuscular.
oxytocin.
Yes.
There was one study, I was going through it. There was one meta-analysis. They have seen that carbetocin, if it is given in the umbilical vein after the delivery of placenta, in retained placenta, these results are found to be good.
Can we use carbetocin in Rh negative mothers?
I think we can all use the carbetocin in Rh negative patients, but I think because the contraction is so strong, so we should definitely see the blood group of that patient, and we should definitely give the NTD if as early as possible, so that there's no mixing of blood. And preferably in the Rh negative patient, we should give the prophylactic dose at 28 or 30 weeks. That is going to be very fruitful, because in such cases there will be not mixing of maternal and fetal blood. This is my opinion.
And in Rh negative, if they get PPH, getting blood also will be difficult.
Blood is very difficult. Sometimes blood is not available.
Yes, maybe.
So we use it, and there has been found to be good.
Can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction?
Definitely we can use it. It has been a good experience. No problem at all.
And carbetocin and oxytocin is a textbook brand. It has been used always for labor induction. Is there any specific condition where you would prefer IV route or IM?
If there is some, I already told you that if there is some anesthesiologist is definitely
not there
present, so then we use the anesthesia is present, then we use the IV. Otherwise, in normal delivery, we can just give the IM also, because there is staff for our staff. We don't let them give IV because they may give a rapid shot. Then we might be in a problem, because in normal delivery we don't have much stuff with us. In cesarean, we have assistant staff is so much. So we have to be careful. This is my experience, and this is what I follow, sir.
If the patient is not responding adequately with carbetocin, which other additional neurotonics you would use?
So if the patient is not responding to the carbetocin, then we can use misoprost or misoprost.
So what is your first choice, madam, after that? Misoprost?
First choice, I will, if the patient is at-risk patient, then we will give the carbetocin to the patient is at risk. If it is not available, then misoprost. We are doing using all these things together. In some patient we use carbetocin, in some patient we do oxytocin, in some patient we take misoprost, depending upon the patient.
And in severe cases, we may have to use all. Yes. That is also possible. We can't take any risk.
Yes.
Advantage of carbetocin over oxytocin, misoprostol. I mean, you have said so, but specifically over this misoprostol and carboprost, any specific advantage?
Sir, on oxytocin, it is the cold. We have to monitor the cold chain during the transport. Also, it is we have to keep in refrigerator. Sometimes we don't have refrigerator in our OTs or in our labor room. We keep it in the OPDs. So sometimes we just forget to take those injections inside. So the carbetocin in this way is very good, and the result, the fall in BP in carbetocin is slightly less as compared to the oxytocin, and the antidiuretic effect of carbetocin is less than the oxytocin, and there's no effect on the breast feeding for the
and
baby.
Even on the blood pressure, like methyl ergometry will give high blood pressure.
Yeah, and misoprostol, although it is very good, sometimes the patient has a lot of pain. Patients sometimes they have fever. with misoprostol.
Misoprost, yeah.
So the fever is not with carbetocin. Some of the patient is already febrile. We won't give misoprostol in such patient. If the patient is having infection, also there also we don't the misoprostol. Carbetocin we can be used. And carbaprost, we have to see that the patient does not have an allergic reaction or asthma patient.
Correct.
Although carbetocin is also contraindicated in asthmatic patients. And methyl ergometrin is not to be given in patients who are having high BP. We don't give.
Correct.
But in lower uterine contract, when sometimes we want the lower uterine to contract, then misoprost, then methyl ergometrin is very good.
Achha.
Otherwise, for the upper uterine segment contraction, oxytocin, misoprost, and carbaprost, carbetocin, they are very good.
Yeah. Very interesting. So whereas upper uterus is concerned, carbetocin are others, but when it comes to lower, it's only methyl ergometrin.
It is very, when there's bleeding from the lower uterine segment, the methyl ergometrin works very well. Very well.
And I mean, you have answered this already. Should it be kept as a reserve drug or should be first line? I mean, you have answered this.
We are using all these things together, sir. So
and obviously, I mean, first line is obviously needed. Whatever is needed to save the patient.
Yes. These we are not saying whether the cost is much or not much.
Well,
so
what is
we are
stake,
using it.
Yeah, correct.
For government setup, I think they might have to consider the cost effectiveness. For private practitioner, I think they are doing 10-15 deliveries per month. So I don't think they will be having any factor of cost regarding because they have to just save the patient at any cost. They don't want to take this because they don't have much of assistance in private sector. So in government sector, there are a lot of doctors, senior residents, junior residents, professors, and so many things. So they can take the risk. We can't take the risk.
No, we can't.
Yes, sir.
How do you compare adverse effect profiles? What you have said is, but adverse effect directly vis-a-vis oxytocin, immediately is there a side effect or a little delayed?
So the side effects are just nausea, vomiting. Sometimes there may be tachycardia also. There might be flushing of face also. And they
remain for a short time, obviously.
Electrolyte imbalance can be there. They say that you have to do ECG also of such patients. Yes, if the QT interval is high, then in such patient we have to be very careful. And electrolyte imbalance, if the patient looks very dehydrated, if there's hyponatremia, we should be very careful because such patient they go into hyponatremia. There may be confusion and delirium of such patients. Some patient they may throw fits also. So in such patients, if the QT interval is more, or if the severe cardiac patient, asthmatic patient, or the patient is of migraine, so in such patient we should avoid the carbetocin. Otherwise, we can use these patients very well.
Take home message on carbetocin.
So it is quite effective. So my experience and experience of my colleagues is very good. So we can very well use it. And so because we want to avoid the PPH, we have to give prophylactic dose. We have to just give single dose. We have to give. We don't need to repeat dose, and it has got a very it has got a half-life of 40 minutes, and it can act even up to 12 hours. So we don't need to give additional.
That's correct. That is very important.
Yes. So it is very important. I think it is very useful drug. So efficacy wise, safety wise, and it is best tolerable drug. So it is quite good. My experience and experience of my colleagues, it has been very good.
Thank you so much, madam. It has been wonderful sharing your experience.
Thank you, sir.
We also got some insights into the whole PPH. Like I said, we see textbooks more than patients, but then this has been a really good experience. Thank you. Thanks all the participating doctors, all the doctors who have attended this webinar for their for taking out time from their commitments and schedule and attending the programs. Thank you, marketing team Hitro, for conceptualizing. And once again, thanks for the field staff of Hitro for excellent coordination. Last but not the least, let me thank IT team of Hitro for this super help, IT help for this. Thank you once again. Wish you a very good afternoon and good evening. Signing off. Thank you.
Dr. Kamla, if you want to share your experience, you can please. She's muted. Thank you, sir, so much.
Thank you. Thank you so
Thank you,
much.
sir.
Yeah.
Thank you, sir. Thank you. Namaskar, sir.